I'm Dr. Virgie Bright Ellington, and on another very special episode of What Your Doctor Wants You to Know, Ask a Doctor what your doctor wants you to know with Dr. Virgie. We are joined again by popular demand by the awesome, good Dr. Virginia Dee Banks. Dr. Banks, MD, MBA, is an infectious disease physician with Northeastern Ohio Infectious Disease Associates of Youngstown, Ohio. Dr. Banks is the former chair of infectious disease at the University of Pittsburgh Medical Center, Hermitage, PA campus, and member of the Food and Drug Administration, FDA, Anti-Infective Advisory Committee. So when Dr. Banks was with us last time, we got such an overwhelming positive response. Everybody said, my gosh, she's so sweet and so smart. Can you ask her about monkeypox? And I'm thinking, monkeypox, that's really interesting. So people ask, could she come back and talk to us again? And she's so gracious to take time out of her incredibly busy schedule and talk with us. Welcome again, Dr. Banks.
Thank you, Virgie. I'm happy to be back, and honored to be back. And thank you very much for asking me to come back.
It's our honor and privilege. And the thing about monkeypox is I have to be honest with you, I was stunned that folks were asking me about it. The feedback I got, they were like, yeah, okay, it was nice to hear about HIV, but what about monkeypox? We don't hear about HIV, we hear about monkeypox. And I was stunned to hear that, Dr. Banks, because I thought, HIV, this is something that is ubiquitous, it's endemic in the population, it shouldn't be. And we got from our conversation with the good Dr. Banks, learned that it doesn't have to continue, that we can stop it cold with PrEP, right? With prevention medication.
Yes.
Okay. So I was really stunned when they said, well, we don't care about HIV. Tell us about monkeypox. So this is really interesting because I live near the current epicenter in New York City. And there was an article that came out yesterday in the New York Times that talked about monkeypox and the big public health issue, what it is, how to treat it, and how to prevent it. So Dr. Banks, can you tell us a little bit about monkeypox, its history, and how we got to where we are today with this current outbreak in the U.S.?
Sure. So, I guess monkeypox for me is more job security. I certainly don't like to think of it that way, but just when I think, my head's coming out of the water a little bit, there's something else. So, several months ago, we started to hear about monkeypox. And, of course, as an infectious disease specialist and having studied geographic medicine and so forth, it wasn't new to me, but and we knew, let's talk about the geography, the geographical distribution. And this really was a virus. It's a member of the orthopox virus group family. The same virus that causes variola smallpox, or did, because we have eradicated that, the only infectious disease that we've ever eradicated in 1977. So it was basically a disease in Central and West Africa, and I think the first outbreak actually happened in Denmark in 1950 from some laboratory monkeys from Singapore. And these animals were used in, an experiment. And so this is what we call a zoonotic infection, an infection that comes from animal to man initially. And so, that's really the place that we started to hear about it. The Democratic Republic of Congo, it was formerly called Zaire. So, it's again one of those type of infectious diseases that really had just pretty much found its place in Central and West Africa. But then we started to hear, I don't remember exactly when I heard this because everything sort of crosses, but let's say 6 or 7 months ago, we started to hear of the emergence of the monkeypox infection into countries where it's not endemic, European countries, and then eventually into the United States as everything happens, because you can be on a plane this morning and be in Australia by the next day. And so it started to spread. And I tried to update myself today. I think it's at least 15, maybe 22 countries where this monkeypox has spread. And there, at least in the United States right now, there are 1,972. And what we have done previously is, like I was talking about Ebola. Previously the way we kind of looked at things, especially some of these zoonotic infections, and even some of the previous coronavirus infections, SARS and MERS, well, it was over there. It's not really going to get here. But I think we got caught sleeping at the switch with coronavirus. And what I can tell you, I'll tell you a little bit more about the rash and so forth, but I can say that I really feel the United States right now is not going to get caught again with this. Now, nothing is 100%, with at least it being out of control. I have a lot of friends who are in the CDC who told me, even of recent times, that in terms of the spread and vaccine distribution, which we'll talk about a little bit more, we're good there. So what is this? It's a virus that causes what we call a vesicular rash. It's sort of like what you see with chickenpox, little pustules. And typically it starts on the face and spreads outward. And, it can occur on any parts of the body. And, we see these pictures, and somebody said, well, why do you see pictures with only, people of color? Well, historically, that's where the virus has been. There was no prejudicial thing about taking pictures of monkeypox. That's in order to show the extent of the disease. The most pictures that we have are from, where it is endemic. So it's continued to be somewhat of well, at least right now, there's still low incidence. But I think what has come to the forefront are the individuals that are being affected. And I think I also want to make a comment too about, so it looks like the virus, but I have some feelings about this. The virus right now is spread contact to contact, close contact with somebody.
So skin to skin.
Skin to skin, skin to skin first. It can also spread on fomites.
Okay.
It can also spread on sheets, and those are things that we call fomites, inanimate objects.
Right. So a person who's infected, they can, even without lesions, when they're contagious, they can transmit it by just touching surfaces and somebody coming after them and touching those surfaces.
Well, the issue of asymptomatic spread, so if you're not having any pox lesions, right now we call that asymptomatic spread. So the jury right now, at least today, July the 19th, is out. They're looking at asymptomatic spread. But the kind of spread that I'm talking about is if you have vesicular lesions, and of course they're going to drain just like chickenpox. And so the virus is then going to end up on clothing or sheets or towels, those kinds of things where the virus can live for a particular period of time on these kind of objects.
Door handles, kitchen utensils, cups.
Right. But a lot of those things that you may have closer contact with, like sheets and towels, using somebody else's towels and sheets, where your exposure to a cup might not be that long. Okay. And also cups and those kinds of things, the virus probably doesn't live on them, and you're probably not going to have a lot of draining lesions on a coffee cup or those kinds of things. It's mainly those things that you're going to come in contact, borrowing somebody's clothes.
Yes.
Who have somebody who has those vesicular lesions. And because people do tend to use other people's towels. That was the thing that we learned with spread of MRSA. We had families that were exchanging, using the same towels and stuff. We were trying to figure out, well, how can we stop MRSA? Well, they were using the same kinds of things. So when we talk about respiratory droplets, at least according to the CDC, theoretically, respiratory droplet transmission is possible. Now, I personally, Dr. Dee Banks, and this is only Dr. Dee Banks, and I was correct with coronavirus. as I'm watching the trajectory of this spread of this virus, I find it a little hard to believe that this is only human close contact with skin to skin, or like I said, with using sheets or those kinds of things. Because the trajectory, at least in the European countries, initially tended to be sort of logarithmic. And, I was like, well, you can't have that many. It was just like with coronavirus. When you started to see the trajectory of how this thing was spreading, you couldn't have that many people that was next to a person that was next to somebody that was next to somebody that was next to somebody next to somebody. I am waiting to hear what shakes out in terms of respiratory spread. And when we talk about contact isolation, I'm not sure, I don't know right now where the CDC is on wearing N95 masks when we have a patient, but I do know that they want people in negative pressure rooms. So a negative pressure room is air where air is being recycled out. And you have to have so many exchanges. That came about because of tuberculosis. So negative pressure rooms came about because tuberculosis is so highly spread from a respiratory standpoint. So I'm just a little concerned right now of whether or not we're going to see, or is there an issue with respiratory virus. The demographics of this right now, it appears, involves the LGBTQ group. And I want to preface this by saying what is tending to happen is, again, the stigma that attached to the LGBTQ group, just like HIV/AIDS. And whenever I've started to give conversation or lecture about this, I'm very concerned that this doesn't turn into another panic like we did with HIV/AIDS. Now, right now, at least from what we know, and again, what we know is July the 19th, 2022, they have looked at, situations where there has been close contact of members of the gay, bisexual community, circuit parties, if you will, where there are large groups of people coming together, individuals who have multiple sexual partners, where there may be contact with someone. So those primarily are the focus, if you will, on the spread in the LGBTQ community. That is also, and why is that important? Because that is also important because a lot of my learned scholars, colleagues, are calling for more emphasis and looking at, should we be vaccinating more people right now in that community to what we call, just like with HIV/AIDS, pre-exposure prophylaxis. Now we know you probably should prophylax somebody who's been exposed to somebody with monkeypox, but where the conversation is going now is pre-exposure prophylaxis with the vaccines that we have. We have 2 vaccines right now, and they're all, based on the smallpox vaccine, which is, it's a smallpox virus. So there are 2 of them. One is called, that the FDA has promoted, it's called Invanex. And right now we're a little bit short supply of that. That's again one of those things we're sometimes behind the slow with that. And then there's another one called, I believe, AMCAN 2000. Now we have an ample supply of that. And if you read the CDC, we'll talk about that, cdc.gov / monkeypox, even / vaccines. They have a whole section in there on at least what we know right now in terms of efficacy of both these vaccinations. And it appears right now that we do have ample supply for everybody. Even if they don't have right now the Invanex, we do seem to have an ample supply of AMCAN 2000. And this is where the United States has done well in getting ahead of the game before this starts to spread more, because I still don't know what the trajectory of this virus is going to be. You tell people about, avoiding contact with other people who have it, but, that's been hard. That's hard with coronavirus. So I think we try to do as many things as we can to mitigate the spread. But we're right now at 1,900 cases in the United States, and I'm not sure how many there are in the European countries. But remember, this is the summer. People travel. People are on planes back and forth. So I predict that the numbers are probably going to get higher as we get closer to the fall. So what can you do? I mean, I think that everybody needs to be their own advocate. I don't think, I think you have to look at learned sources. I mean, the New York Times always vets everything that they put out. And again, CDC.gov, they're very careful. Sometimes they got faulted during the coronavirus, and they still are. But they're careful. They're a federal organization, and they really have to. And Dr. Rochelle Walensky, I know she wants, before she dashes out there with any commentary, to make sure, because once it's out there, once the cow's out of the barn, especially with the federal government organization, it's hard to bring that back in.
Once you've rung that bell, you can't.
Yeah, so I just say to everybody, this is it's an ongoing situation. And I do think that everybody needs to be vigilant. And I do think that those members of the LGBT community do need to be vigilant and understand the transmission of this. I think more doctors are getting educated. And certainly we do have a major resource in New York City. One of my friends works there, the health department, and they're on it. So, in terms of questions, if you have questions, now if you're going to get vaccinated, it should be at least within 4 days of exposure. So what does it look like? Again, vesicular lesions all over your body like chickenpox. What can it look like? Well, it can look like herpes simplex. It can look like syphilis in some situations, which is why it's good to not self-diagnose. And you probably should go see your healthcare provider, who can then refer you to someone that's a little bit more educated about this. But we're all learning. I don't pretend to be an expert on monkeypox because I just learned about it coming into this country when everybody else did. The difference is I've had to dance as fast as I can to get educated about it, because you have to stay ahead of patients that are going to be calling on the telephone wanting to know, well, is this what I have? Right now, the specimens are being done by PCR, polymerase chain reaction. You can also do testing with serum immunoglobulins, like IgG and IgM. And the difference is when you look at like herpes and you want to test with IgG and IgM, you can't use that because almost everybody's been exposed to one of the herpes viruses. Right. But you should not have an elevated IgM immunoglobulin with monkeypox. So if your IgG is elevated, you have it. Or if it's even present, you have it, because this is not a virus that's endemic anywhere, unless you've been in Central or West Africa. So those are sent down now to the state. I know in Ohio, they're sent down centrally to the state of Ohio, just so they can get some idea of who's being infected. And again, doing those things like demographic spread, and also trying to make sure. One other thing, there's so much to say, so little time. Since we've last spoken, I was just appointed to another committee. I need something else to do. Another committee under the under the Assistant Secretary of Preparedness, and that's under the Department of Health and Human Services. And they brought together a number of us, and this has relevancy to monkeypox. They brought us together from the Infectious Disease Society of America and from a Department of Health and Human Services to try to figure out how we can have equitable distribution of COVID therapeutics. And it's the same for monkeypox. And if you look at the CDC.gov, they're already talking about equitable distribution of vaccines, because we know that there's some people that are going to have access to it and some people are not. That's just the way it is. And so now, having learned that game, knowing that there were healthcare disparities with treatment, or let's not talk about past tense, there were and are healthcare disparities about distribution of medicines, treatments, and vaccines. We don't want that same thing to happen for monkeypox. So they're already on it. And I don't know if my committee will be given the charge. Right now, we're busy with COVID, but it's the same thing with monkeypox. We know that probably those people of color, let's just call it what it is, may not, I'm not saying that that is going to be the case, but we're talking historically, may not always have access. And then the other thing, dealing with coronavirus, you weren't necessarily dealing so much with stigmatization. With this, you are. Now you're ferreting out again people who wanted to keep their own private business private may now have to come forth and reveal their sexual preferences. And so that puts in a whole nother, then maybe people aren't going to be as forthcoming about saying that I exposed somebody or that I was exposed. You understand where I'm going with this?
Exactly.
So it's big. It's big. There are a lot of moving parts here. This is not exactly like coronavirus because you now have social issues that you have to think about.
The thing that was discussed, to your point, Dr. Banks, repeatedly in the New York Times article that came out yesterday, July 18th, 2022, about the monkeypox cases in the New York City area, which is now the epicenter in the United States, is just that, about this stigma because of its transmission with men who have sex with men or men who have had sex with men. It's starting all over again. And in this article, there is a group of folks who historically are marginalized and don't have access to care. Now, the U.S., we know this, we talk about this all the time on the Ask a Doctor show with Dr. Virgie. It's a two-tiered health care system in this country. There's always going to be folks that have resources and folks that don't. And the folks that have resources had access to one of the patients that the article, the reporter or the journalist interviewed is an attorney who was well connected. However, he said, I'm worried about folks that are not. And so we're talking about a huge Latino population that don't have access, that this lawyer, he says, I know I have access and I'm worried about those that didn't. And he talked about the difficulty he had with advocating for his care and advocating to get tested and then advocating to get vaccinated while, he got the test finally, but it takes a long time to get back. And, the health department is overwhelmed. They don't get back to you. Cases, they just don't get back to you. So in the meantime, one of the patients interviewed, one of the folks interviewed in this article was living with an immunocompromised 76-year-old grandparent. He says, look, I think I have this. You're not sure, I haven't heard back. I'm miserable. I'm really sick, but I need to protect my grandparent. He needs to be vaccinated. What do I do? So they talked about the issues with access, and it turns out to be, the same old story we hear about historically in this country. Folks of color have historically had limited or no access to healthcare in this country. And we saw, as you said, with Corona, it's a problem. It doesn't matter. The viruses don't care if you have access to care or not. You don't want folks driving on the street, walking the street with you and yours who don't have access to care. Everybody needs to have access to care. So one of the things they also talked about with the virus is that they're finding out that there there seems to be some significant asymptomatic spread. And with men who have sex with men, the lesions, they start out before the lesions, they start out really, really sick with, nasty, high fever, just feeling horrible. So to your point, saying, the stigma, folks going to their care provider and saying, look, I think that I may have been exposed to, my lifestyle is such that I have risk factors for being exposed to monkeypox. That's going to be an issue. And then, folks talking about their risk factors, they may not get swabbed. If the lesions are in the mucosal surfaces, in the anal surfaces, in the mouth, they're horrifically painful. and they may not be on the skin. You can't
Right.
see them, but you are miserable and in pain. And you have to have a conversation with your physician to say, I need you to swab my anus. I need you to swab my mouth. That's a hard conversation for many to have.
And not everybody gets to go to an infectious disease physician.
Oh, absolutely not.
We're talking
I'm just talking about basic first
yeah,
line,
just the first
exactly.
responders.
Primary
the
care
first
physician,
responders.
who we haven't been educated about
No,
this stuff.
exactly.
So
Exactly.
nothing about it. So when you're feeling your worst and you the least able to advocate for yourself, and you wanted to keep your lifestyle private for whatever reason. And
Exactly.
obviously,
because you're entitled to.
Never lie to your doctor, your lawyer.
Right.
Right.
But you're entitled to. You're entitled to have your privacy.
Let's talk about, I partied last weekend. But it is what it is. Protect yourself, and you have to advocate and say, you know what? I am in such horrific pain. It drives people to the doc, to their doc.
Right.
Help me. And the docs don't know. So they need to know that the lesions need to be evaluated in the mucosal areas, mouth and anal areas, vaginal areas, and the mucosal surfaces, and it has to be sent to the departments of health. So in New York City, it's New York City Department of Health.
Right.
And as you mentioned, in the state of Ohio, it's the Ohio.
In Columbus, centrally located in Columbus. Right.
So we need to educate our primary care physicians that this is what needs to happen. Thank you so much for talking about the vaccine, because the article also talked about the really limited access to to the virus rather, and the rollout, has been so limited that it's really concerning. Apparently a week or two ago, they had the New York City Department of Health announced that they had 9,200 vaccines, a little bit more than 9,000 vaccines available. It was gone in 7 minutes. So
I believe
you for bringing that up, that there is an okay supply, it seems like, of the MChem 2000 vaccine for monkeypox. So that's huge. We can vaccinate ourselves. Do you know, Dr. Banks, is it one vaccine, one shot? Is it a series of 2 shots?
It's a series of at least 2.
Okay.
And they're spread like 2 to 3 weeks apart, something like that. And you're not immunized. It's sort of like with coronavirus. I think with the Immunovax, it's 2 weeks. And I believe with the AMCAN 2000, you're not fully immunized until 4 weeks. But it is at least 2 vaccines with it. And this is as of, again, July the 22nd, July the 19th, 2022. And like I said, a lot of for example, under the Infectious Disease Society of America, there's the HIV-MA, the organization, the HIV Medical Association that's under the Infectious Disease Society. And many of my colleagues that are actively involved in HIV work are really advocating for a lot of because the HIV patients are immunocompromised, many of them. I know they're on medication and so forth, but if you're talking about distribution of vaccine, you certainly need to put those patients on the list. And again, the CDC, and I know again, they're very slow sometimes to roll out, and I can't really criticize them because I don't have Dr. Rochelle Walensky's. It's always easy to be an armchair quarterback. But what happens is things happen so fast and furious. I just want to get down to one thing. That I was doing a webinar one night with individuals that were, not physicians, but intelligent and educated. Let's put it that way. You don't have to, they're educated. And I just asked a question. Does anybody know where do you make a phone call to get a COVID vaccination? Just the one phone call. Just tell me, if you wanted to get a coronavirus vaccine, what number would you call? And so it's the simple things like this where I'm not seeing the algorithms. And again, I'm very actively involved right now with coronavirus. When I think about these things, people have to have algorithms. if this happens, where do I call? Who do I go to? If that person doesn't answer, then where do I go? Because people panic, or people just say, the heck with it, I'm not going to do it. Now, that leads to several things. Either they could get sicker, although this tends to be a self-limited infection, but some people can get really sick with it depending on their immune status. And you can give it to other people, like you said, that person in the house. I mean, when we talk about immunocompromised patients in this country, one of the good things about cancer treatment and cancer chemotherapy is that we've got a lot of drugs now that have extended the lives of people. But many of them I call the mob drugs, the monoclonal antibody drugs. You know what I mean, Doctor?
End in AB, yes.
They render people immunocompromised.
Yes.
And so, while they've done great things, now they're susceptible to getting infected with some of these viruses, and again, if they belong to a certain demographic group, as we are seeing now. But again, I think we have to wait and see how this is going to be. Remember how HIV/AIDS started out? I remember, I was a relatively young doctor then. That demographic was how it started, but then came along the demographics looking at Africa. And that's when we realized that there was a significant heterosexual spread of HIV/AIDS. So that's why I'm a little leery to all of a sudden jump and just say, well, this is just an LGBT virus. Let's wait and see
exactly
what the trajectory of this virus is going to be and who is going to be affected. And again, like you were saying, I'm shocked. 9,000 doses gone in how long?
7 minutes. Less than 10 minutes. 7
As
minutes.
they say, Houston, we have a problem.
Yes, ma'am.
So, I think I'm not, I don't have day-to-day contact with the CDC like I do with coronavirus, but I'm sure they read that article, and I'm sure they're aware, because the health departments all have to report there too. The CDC has their fingers on the pulse of all the health departments, because all of them are federally funded. So they have to know all of this information. And I would have to say, that's shocking. That's shocking.
It's difficult to have the ramp up. We're still reeling from, COVID-19. And to your point, we've learned things to be able to ramp up quickly and respond quickly. And, here we go. We have to be ready. We've learned many lessons, hard-earned, painful lessons from COVID-19. And you were saying, let's keep it moving. And we understand that resources are limited. And still, to your point, there needs to be the algorithm that we've developed from our experience with COVID-19 to be able to get ahead of it, as you said, Dr. Banks.
And I don't want to be a Debbie Downer. I know we have to end this segment of it. But let's just also think about the work that I've tried to do as a trusted messenger in getting individuals to get vaccinated. Now, there are some antivirals that are out there that they're looking at and to use with monkeypox. Some of them we've used previously with HIV/AIDS. So now we're going to have to convince maybe that same segment of the population who had vaccine hesitancy. And they're looking at me like, you want me to what? What do you want me to do? So, there's going to have to be a lot of messaging from trusted messengers. So you're talking about the vaccine, 9,000 went out in 7 minutes. Those are the people that wanted to take it, not all the people that necessarily needed it.
Thank you. Or aware that they need it. We don't have the messaging to let folks know that, hey, you may need it. Find out more. So we're going to have to do a lot more messaging to people about the what's in the what are they? Are these live virus vaccines? I believe most of them are live virus vaccines. So we're going to have to do more educating of people, and I'm sure right now they're working on second generation of these vaccines. That's what they do.
But again, one of the vaccines, I think AMCAN can't be given to individuals who are severely compromised, immunocompromised. So, a lot, like I said, a lot more messaging has to go out. And I don't know, these are the conversations that I'm having with this new committee that I'm on. Do you use social media? Do you use Facebook? Do you use Instagram? What are the major mechanisms for getting information out like that? Television? Do you do it with a movie star? And a lot of times you don't have a lot of time to scratch yourself on the head and figure out, so you just have to have a mass effect. But not everybody reads the New York Times.
Exactly. The answer is yes. Yes to all of the above.
All of them.
Multi-pronged approach.
Yes. Multi-pronged.
The thing that I did hear about and read about in that article about the treatment for monkeypox is a treatment, an antiviral that was originally developed for as part of the smallpox bioterrorism unit, and that's where it originally came from. It's called, and I'm reading this now, T-pox. And that's T as in terrorist, P as in pox, OXX. And the full name is tecovirimat. And they're saying that it's only available through submitting paperwork to the CDC.
Right.
So
and I've been told that the paperwork, I've been told that the paperwork is enormous.
It's hours and hours and hours.
So you and I have not had this conversation.
No,
we haven't talked.
No, we have not talked about this.
And a lot of doctors are complaining that they've been getting bogged down when they wanted to use this antiviral because of the reams of paper that they've had to go through to get. And we had the same thing with coronavirus when we started to use remdesivir and some of the other drugs, that tocilizumab, and all of those. The paperwork was enormous, and that's a barrier. That's a barrier. So you're absolutely right.
Yes. The issue is that it takes these reams and reams and hours and hours and hours of paperwork is because it's only available through a compassionate use protocol. You've talked about algorithms. Should we not have these treatments under a compassionate use only protocol when we have an upcoming
epidemic
of a virus? So that's another story for another day, but it is where we are.
That's a tough one.
That's how to get the meds, the treatment.
That's also another conversation with healthcare disparities.
Dr. Banks, can you come closer to the mic?
Sorry.
I can hear you now.
That's also a situation when you talk about healthcare disparities. Because compassionate use, some people are going to get it and some people aren't.
We're back to that, exactly.
It always comes back to that.
Folks having access to care.
Yeah.
Exactly.
It always comes back to that. And now that we're looking back on coronavirus treatments and so forth, I'm sure it's going to shake out that there were certain segments of the population that didn't get remdesivir or didn't get tocilizumab or didn't get baricitinib or some of the drugs that we are using and have used. It always gets back to that. And that's why we have to stay vigilant. And when you say, well, should we not have it for compassionate use?
Only. I think, should it not be held under the compassionate use only protocol?
They'll probably expand that. I look for them to expand that. This is just the process that they're going to, and also making sure that they have ample supply while they're, revving up their supply. But it always is going to come back to that of who gets it and who doesn't, even if they need it.
Yes.
Because not everybody has that doctor who's going to fill out that paperwork.
Exactly, or has staff that can fill out the paperwork with them for them.
A lot of patients go to a lot of the facilities where the physicians are dancing as fast as they can with a lot of other things, and they don't have somebody assigned to them that can do all this. And it's enormous. I mean, we did it for coronavirus. And so, what they need to do again in various cities is maybe identify somebody that can help navigate through that process. We need more navigators through these processes of filling out paperwork and getting these patients medicines as soon as possible. Healthcare facilities need to. We had that. We actually got our pharmacists involved with that, where many of them were helping to fill out the paperwork. But that's not in an office situation.
Right.
So you understand how it's not just the monkeypox and the vesicular rashes. It's all this other stuff that goes into treatment and vaccinations. That's enormous. That comes back to the same old problem of who gets it and who doesn't. And gets back to the same old problem that we had with HIV/AIDS, the stigma that's around this disease. And so, you think that we progressed.
Others.
Yeah,
Correct.
you think that we progressed in this country with a lot of the, that great Broadway play now that's on, I can't think of the name, but they won a lot of Tony Awards, and it's about, a young gay individual, and about the gay population, the LGBTQ population, and it's won tons of Tony Awards.
You mean back in the day?
It's called something, is it called Something I Learned Online or something like that? And it was a young African-American male who wrote it.
Wow.
And he's just fabulous.
Dr. Banks, I don't get out much, so
I'm
not going to know.
But it's a good play. And my point about that is that you would have thought that since the movie Rent came out and Rent on Broadway came out, that we would have progressed in terms of the way our country looks at LGBTQ, from political and social determinants and all of that. But there's still the undercurrent.
Yes, ma'am. Exactly.
It's like racism. There's still the undercurrent.
Yes.
And what we have to continue to do is to continue to fight against that, because now we're talking life and death. It's not just a philosophy that somebody has that I don't like you.
And you know what? They are connected to someone that you love.
Right.
They are connected to someone that you love, and they're out there in the world, in the streets, driving, walking, talking with people that you love. So that's why it's important to take care of all of us.
It is. It is.
That's a great segue to talking again about taking care of all of us is the latest with COVID. We're talking about the new variants coming out, and they're more transmissible, much more contagious. Dr. Banks, can you give us an update on the latest and the greatest with COVID-19?
Well, it's back. In the hospital, as you all know, I'm in the trenches every day, and I'm just continually amazed and getting somewhat down about going in the intensive care unit on the floors and seeing that dreaded droplet protection sign that 9 times out of 10 is coronavirus. And so what we have now, we have these two variants, B4, B5, that again, you keep going about one is more contagious than the other. I don't know how much more contagious they can be. We were talking about me having coronavirus when I got back from Italy, and that happened. I mean, the incubation period for me was about 24 hours.
Yes, one day.
Yeah, so they're working on, I am told that they're working on a vaccine that will be coming out, and because the problem that we're having now is that the vaccines that we have, even if you've gotten that second booster, they're not capturing B4, B5. And so we're seeing a lot of people, and a lot of, I can't say now that before, that person's not vaccinated. A lot of the people that are coming in did what they were supposed to do. And it's not just mild infection. So, it's a mild infection and it's not that bad. Some people may get Paxlovid, some people might not need it. But now I'm seeing people in the intensive care unit on ventilators again.
Now, who were vaccinated, who got at least 2 shots. So we said, it'll mitigate the disease, the infection if you do get infected, but we're seeing strains, and I tell people it's just like influenza virus, except what's so deadly and the problem with COVID-19 is that the genetic shift and mutations, instead of once a year, every 6 months to 9 months is like every freaking 6 days to 6
Exactly.
weeks. That's the problem.
That's the problem.
Why we're in trouble.
That's the problem. That's the problem. And I have to tell you, yesterday I had 30 patients in the hospital right now because we're sort of short staffed, and I walked into the intensive care unit and I was called for just a patient who had urinary tract infection or whatever. But there this person did what he was supposed to do, droplet spread, protection. And you just know that it's, and I'm thinking, and this is what happened in last September. It's the drip. It's the drip. Emergency rooms now, you start seeing them coming in. Well, a couple of months ago, it was that mild infection. And now we're seeing patients come in that are the word hypoxic, meaning that their oxygen levels are low, just like it was before. And I don't know. I'm still pushing for people, to get whatever vaccine, to continue to get vaccinated. But some people are asking me, well, it's July. Do you think I should wait? I'm betwixt and between because I really haven't heard anything from the powers that be. I'm telling individuals right now, you have to look at what your own individual risk factors are. And, not everybody's in the picture that I'm painting, people in the hospital. That's not for everybody. I didn't end up in the hospital. So I believe that my vaccinations, they may not have completely covered B4, B5, but they kept me from being hospitalized and they kept me from dying and all of that. So I think there's still a need for vaccination, but you have to weigh your risk. Is there a reason to think that their vaccine is going to come out in September or October? Yes, but as you just pointed out, there will be another mutation. What did you say, 6 days?
Yeah, I'm thinking, this joker is like, every 6 weeks instead of like, 6 to 12 months,
right.
6 to 9, 12
it
months.
It is the smartest virus.
Joker, exactly. It's
the smartest virus that we have known in recent times, in times that we have records to go back to. Yes, it is the smartest virus. And so, I'm not trying to be glib in saying that we have to live with it, but because people are not going to we're not going to get back to complete shutdown like we were before, because there will be complete anarchy in this country. I don't think our economy can take it. But I would just say to individuals, do whatever mitigation you can do. Where I dropped the ball was I did not, after wearing my mask in Italy, K95s, KN95s, and N95s, I didn't wear my mask on the plane. Well, that was just plain dumb. So, 9 hours on a plane with no negative pressure. They have HEPA filters, but that's just not like negative pressure. So you have to do whatever you can do. On an airplane, I would strongly encourage masking. And I would strongly encourage, now that we know the numbers are starting to uptick, it's okay if you're in, I'm not saying don't have a picnic with your family, but you might want to rethink putting a mask on.
My best friend from first day we met, we were both still 17 years old, first day college freshman English. And she laughs at me when I have certain phrases, she calls them Virgie-isms. But one of them is, she says, Virgie, I keep hearing your voice saying, planes are just flying petri dishes. When it comes to corona, when it comes to things that are respiratorily transmitted, it is what it is. It's just because of, being able to fly in the air. There are certain things you have to do with physics that you can't do to protect yourselves against respiratorily transmitted infections and, microbes.
It's true. And I have at least 10 friends who traveled to Europe within the last 2 months. I would say 90% of them came back with coronavirus, and I think, again, you're on a plane, if you're not going to mask, and then, you're over there, you're having a good time, you may not be wearing your mask and so forth and so on. International travel is daunting. Traveling is daunting today. And then when we're seeing all this information about cancellation of planes and having to stay in airports longer, that increases your exposure.
For hours and
being
hours.
on planes, your plane is canceled. Now instead of doing one leg, you have to do 2 or 3 legs. All of that increases your exposure to a virus that doesn't care. It's not asking how many legs you have. How many legs of traveling do you have? All that virus knows is that it's like I told my 104-and-a-half-year-old mother, pull the shade down. That virus is looking for you. It's just looking for somebody.
Dr. Banks, tell us your mom's name again.
Her name is, she's a doctor of education, Dr. Virginia K. Newell. And she's living in Winston-Salem, North Carolina. And she got her doctor of education in mathematics in Sarasota, Florida. And before
what year was that, Dr. Banks?
She got her, that was 1977. And since that time, she has she's continued to reinvent herself after she retired finally from Winston-Salem State University, where she was, really influential in getting the first computer lab started. They have the computer lab department named after her. She then went on to become a real estate agent.
Oh my goodness.
And appraiser.
I didn't know that.
In her 90s, she was selling real estate. Yeah. So, she had some clients that she worked with, Dr. Maya Angelou, and a lot of people who trusted the brain of a 90-some-year-old. So, what I say about age is look who we're taking our instructions from, or our not day to day, he was more visible. But Dr. Anthony Fauci, I think just turned 82.
Isn't that crazy?
So he's just,
just like you, he cut his teeth on the first, pandemic epidemic in the world, which modern day world, which was HIV. He
did.
Yeah.
He shepherded us through that. Yeah. He shepherded us through that, just like he's been shepherding us. And he just got coronavirus.
Yes.
I don't know if you heard that he just got that, and then he ended up having rebound with that as well. So it took us 2.5 years to get it, but it finally got us.
Yeah. I thought I remembered he got it like a couple of days after you did.
He did. That's exactly right. Right around the same time. Right. Somebody said, "Were you and Dr. Fauci?
Were you guys on that plane in Italy together? Tell the truth.
It was so funny
with us."
It was so funny. But interestingly enough, he took Paxlovid. And although Paxlovid, there are some people that are taking it, I chose not to take it because I didn't think that I needed it. But it has been associated with rebound. And I found that was kind of interesting that he got rebound after taking Paxlovid.
Can you tell us briefly, a high-level overview, what is rebound from COVID?
Rebound is, getting over the symptoms and maybe even testing rapid antigen negative and coming back again with a resurgence of the infection. Symptoms, correct. And maybe even testing positive again.
That was my next question. Okay, good to know. And is that with every the antivirals that we've identified that we're using for COVID-19 treatment?
It's only been
just Paxlovid?
To my knowledge, only Paxlovid. And the thing about Paxlovid, and I do think that those individuals who have a lot of underlying issues, hypertension, diabetes, BMIs over a certain number and so forth, it may be beneficial to them because what Paxlovid does is it shortens symptoms. It doesn't make your rapid antigen test negative any faster. But from everybody that I have gleaned, and I prescribed it to some friends actually, it shortened the symptoms because I have to tell you the symptoms were pretty miserable, and so I thought, do I want to shorten the symptoms? And I'm like, no, I'm good. I'm just going to let my body kick in. So I would say, and I sort of plotted this out, day 1 was my first day of symptoms. I tested negative. Day 2, more symptoms, tested positive. I did not test negative until day 12. I started to turn the corner on day 5. And my PCR was negative on day 21.
Okay.
Now, some people aren't that lucky. The PCR can remain positive for quite some time. I was fortunate, so.
Dr. Banks, you know that we cannot thank you enough for honoring us with your presence and your brilliance. Thank you
welcome.
So much. Where can folks find out more information about up-to-date information about COVID, monkeypox, and any other viruses that are just out there, just part of life that are just going to come at us. We know that we're going to have to live with stuff and just be aware and educated and informed.
I like to have everyone to at least focus on the cdc.gov/, because what I like about them is that they do update the information regularly, within days, as a matter of fact, and it's real-time, up-to-date information as best that they have it. I mean, we have to understand that nothing is 100%. I was talking to one of my patients, the parents of a patient yesterday, and I was explaining to them that medicine is not 100%, but we do the best we can based on the available information that we have at that particular point. And so CDC, I think Michelle Walensky is doing a good job. Remember, CDC not only has to just deal with coronavirus and monkeypox, they have to deal with wastewater situations, which, by the way, I'm seeing, at least there was a report in my state that they're seeing more coronavirus and wastewater.
Yeah, ticks. Yes, yeah.
That we have to deal with.
cdc.gov
cdc.gov/vaccine/monkeypox/coronavirus and so forth.
Excellent. Dr. Banks, thank you. Much
so
appreciated.
Welcome, Dr. Virgie.
So awesome talking with you. Thank you.
Thank you. Have a great day.
You have an awesome one.
Thank you.